what causes pain is actually not the actual stone. And so that's why if you've been worked up for a kidney stone and then your doctor tells you, oh, you have a kidney stone, but it's non-obstructive, what he's referring to is it's not obstructing the urine flow. And that's very important because the urine flow is actually what causes the pain. If you close your eyes and I touch your finger, you can tell me which finger I'm touching. But once it's what we call visceral, it's the organs on the inside, the brain really can't differentiate what from what. And what I mean by that is, let's say you have pain on your right side. Well, that can be due to appendicitis, that can be due to an obstructive stone, that can be due to a mass. Typically, we manage stones not just based on size, but really on symptoms, right? And what do I mean by that? Well, you can have somebody who forms a lot of stone, and basically they are used to passing these big stones, even like a centimeter stone, versus you have somebody who's never had a stone. Well, a 2 millimeter stone can basically knock them out.
Let it's priceless, take it to the moon. Priceless, one day will be soon. Like it's priceless.
Hey everyone, welcome to another episode of D-Talk with Dr. Pham. First off, I want to thank everybody who has downloaded the podcast or the YouTube videos. I really appreciate it. I appreciate the subscription, and that makes me even more wanting to do this, as a service, because there's a lot of misconceptions in urology, which I'm sure in every field. And so if my show can even help one person, then I did what I set out to accomplish. And so, please hit the subscribe button when you get a chance. And the other thing I need to tell you is, like always, everything in this podcast series is my opinion. And so this is not meant for you to self-diagnose and self-treat. The intent is for me to just go over a big overview. And from there, you can have the right questions to ask your doctor, or at least bring up the symptoms with your doctor, because sometimes your primary care physician may not know if you don't tell them, and so that's kind of the purpose of this D-Talk with Dr. Pham in the first place. So today we're going to talk about kidney stone. Now, in one of my previous episodes, I kind of touched on it, but I've been getting a lot of requests for kind of a little bit more detail about kidney stone. And so before we can kind of talk about kidney stone, we got to go back to just basic anatomy. And so basically you have your kidneys here. Now, I'm no Monet, but it'll get the point across, because us doctors are known for chicken scratch, and so picture is no different. All right, so basically, and this is your, okay, so this is your kidney, this is a ureter, and the ureter is what connects the kidney to the bladder, so that blood gets filtered into the kidney like a Brita filter, and that all the waste, water, all of that excess gets turned into urine, and then from there, the bladder empties it out. And so kidney stone in itself doesn't cause pain. Now, I personally never had kidney stones, but I've heard it's worse than labor. Now, I've never had labor either, but just I have a lot of friends that have had labor, and ouch. And so, so kidney stones hurt. Now, there's a lot of misconception that people think it's the kidney stone that's actually causing you to have pain, but it's actually not. So stones in itself doesn't cause pain. What causes pain is normally urine so blood gets pumped from the heart, then gets filtered through the kidney, and then from the kidney, all the excess fluid and electrolytes gets secreted, and that's what we call urine. So it's kind of waste of the body, and then basically the urine then once the bladder fills up, then urine gets out. What causes pain is actually not the actual stone, and so that's why you'll if you've been worked up for a kidney stone and then your doctor tells you, oh, you have a kidney stone, but it's non-obstructive, what he's referring to is it's not obstructing the urine flow. And that's very important because the urine flow is actually what causes the pain. Okay. And what I mean by that is, so, the kidney typically is divided into three parts. What we call the upper pole, which is the upper part of the kidney. We have the middle pole or really interpolar, and then the lower pole. So it's just kind of three section, okay? And now this is referring to kidneys that are not duplicated, but we're not going to discuss duplication of the kidney today. And so basically, if you have a kidney stone that is located here or here or here, it doesn't matter how big it is. It's not going to cause pain, okay? Because urine can still travel down here with no issues. And so what causes pain is when you actually have a stone that is blocking the passage of urine. And so then what ends up happening is the urine then gets back pressured. The urine then gets back pressure and it causes stretch on the kidneys. And when it causes stretch on the kidneys, that's when you see, you may be familiar with the term hydronephrosis or swelling of the kidney. And I don't know why in medicine we have to come up with fancy word, because to me, swollen kidney sounds much easier to understand than hydronephrosis, versus, and then peeing sounds much easier than micturation. I mean, when have you ever come out and asked your friend, hey, do you need to go micturate? But anyways, I digress. But so basically it's the obstructive part that causes the pain. And if you leave it obstructed for a while, then that's when your kidney can actually get damaged. And the kidney, unlike the liver, cannot regenerate. So once damage has occurred, then it has occurred. Now, some of you may be asking, well, doc, like how long do if I have an obstructed kidney, how long do I have before it before it sustained damage? The answer is no one really knows. They may have some dog studies, but I don't think anybody that has kidney stone is probably gonna sit there and try to wait and see how much kidney damage can occur, because you're gonna be screaming in pain, and I doubt it will pass any sort of review committee if you were trying to do a study on somebody who's obstructed versus someone who's not obstructed, because that's basically we know that once you have a kidney stone, intervention is warranted to basically not just help you with the pain, but prevent permanent kidney damage. And so, and I'm not going to talk about syndromes today either. Today, I'm just going to talk about basically overall kidney stone. And so now sometimes you can have, now if it's fully obstructed, then you're going to have pain, and then you're going to need intervention. And usually, what is the intervention? Well, it just depends. It depends on how big the stone is. It depends on the comfort level of the surgeon. It depends on what equipment's available. There's a lot of factors that determine kind of what you do. And so what do I mean by that? So I'll just digress a little bit on that. So if I, for instance, let's say have a 47-year-old that comes in the ER complaining of left flank pain or back pain, and especially in children, it can also present with abdominal pain. And so that's why typically when you come into the ER with pain, for adults for sure, first thing they're going to do is just do a CT scan, because the issue is that through the evolutionary process, if you close your eyes and I touch your finger, you can tell me which finger I'm touching. But once it's what we call visceral, it's the organs on the inside, the brain really can't differentiate what from what. And what I mean by that is, let's say you have pain on your right side. Well, that can be due to appendicitis. That can be due to an obstructive stone. That can be due to a mass. If you're a female, it can be due to an ovarian torsion. It could be, due to bowel. I mean, it's just so much. And so that's where imaging comes in, because imaging is what will help you delineate kind of what's going on. So, but back to the stone. So you have the 47-year-old who comes in, and so they do a CAT scan, and let's say they found a 5 millimeter stone. Well, there is kind of systems out there or guidance on basically, what size and percentage that the stones can pass. And, that you can just Google, and so, but typically we manage stones not just based on size, but really on symptoms, right? And what do I mean by that? Well, you can have somebody who forms a lot of stone, and basically they are used to passing these big stones, like even like a centimeter stone, versus you have somebody who's never had a stone. Well, a 2 millimeter stone can basically knock them out. And so management of the kidney stone for someone who shows up in the ER is really dependent on symptoms and underlying comorbidities. And so what do I mean by that? So if the 47-year-old, so I'm going to give you different scenarios with the same guy, but just different presentation. And then from there, what the surgeon on call or whoever will do. So if you're a 47-year-old guy who comes in, you have perfectly healthy, both kidneys are fine. This is his first kidney stone, and he's in a lot of pain. But then after they hydrate him, then his pain is now what he describes as a 10, now is a 2, and his urine doesn't have any evidence of infection. Then that's somebody that and his pain's controlled with just oral medication, either Toradol, which is non-narcotic, or a narcotic. Then those patients are safe to discharge and follow up with a urologist soon, because both of his kidneys look good. He's no longer having pain. And remember, the key here is pain, because the stone can move up and down. And what I mean by that is there's 3 areas of the ureter that the stone has to travel in order, for it to get into the bladder. And where the part of this part we call the renal pelvis. And so think of that as that's where all the urine collects before it goes down the ureter. Well, where the ureter and the renal pelvis connect, that's the first area that can be hard for the stone to pass, okay? And so, but let's say that 5 millimeter stone made it past that. Then the second area that is hardest for it to pass would be kind of where the ureter meets the iliac, okay? And so it kind of compress it, and so that's the second part where, the stone may not be able to be passed. And so the third part, which is also the hardest part for the stone to pass, is where the ureter actually inserts into the bladder. And so the reason why you have patients that they have a kidney stone and the pain hurts so bad that they go to the ER, but then in the ER they get hydrated, a dose of morphine or Toradol or whatnot, then suddenly they feel fine. They don't really have that pain anymore. The pain is now from 10 to a 2. And the reason being is because the stone can actually bounce up and down. Because remember in the beginning, what I said was kidney stone itself does not cause pain. It has to be kidney stone that's blocking the ureter, causing urine to back up and then putting stretch on the kidney. That's what causes pain. So that's a protective mechanism for the kidney, right? Because when you have pain, then okay, I need to go, to the ER or see my doctor, whatever it may be. Okay. And then, and today I'm just going to really talk about imaging, based on a CAT scan. We'll talk about imaging in general in another episode. So that 47-year-old gentleman, his creatinine, which is kind of an indirect way of just getting a quick snapshot of the kidney, and then, there's a GFR calculation that they do. So if the creatinine's good, his pain's controlled, and his urine is, clear, like no infection, anything like that, then that's someone that you can send home on Flomax, which helps. It's not just for relaxing the prostate, but it helps relax the ureter. Toradol, believe it or not, probably work better than narcotics, and then follow up, with the intent that that stone's gonna pass. Okay, and so now if that same 47-year-old present with a same thing, 5 millimeter stone, and it's lodged right where the ureter and the bladder meets, and you give them hydration, you give them water, all that, and not water, but IV hydration, Toradol or narcotics, whatever, and his pain's still not controlled, then that patient is probably a candidate to have some sort of intervention. And what kind of intervention? And so it just depends on the comfort level of the surgeon and the equipment. But let's say that gentleman lands at an ER that, do routinely have urologic cases, then they should have all these instruments for take care of the stone. So one option is some urologists may like to just temporize the patient, meaning that, the kidney stone is not what causes damage to the kidney. It's backup of urine. So then what they do is they would take you back to the operating room, and then where you urinate out of, what they would do is they would go into where your urethra or your urine channel, and then what they would do is they would pass what you call a stent. And a stent is just like basically it looks almost like two circles connected by a stick, and it's made up of polyurethane. There's multiple different types of stents, and so, but the stents actually has tiny little holes in them, and the most common is usually 6 French by 22, 24, 26 centimeter, and they measure, I don't know why, so there is a conversion factor if you want to know how much the 6 French is, but they measure the diameter of stents, they use French, and then when they measure the length, then they use centimeters. But it has little holes on both sides, and what that does is it'll allow urine to bypass that kidney stone by way of going through those little holes. And so by just the stent alone, it will, it will take away your pain from the stone. However, the kidneys also is getting irritated, and the bladder is getting irritated from the stent itself. And how a patient responds to a stent is all across the board. You have some patients that they don't even feel the stent is in place. They're like, I feel great. And then you have some patients where the stent pain is even worse than the stone pain. So if you have a patient like that, then best thing to do is, after you tried medication and all that, right? Because basically if you have a stent in place, then a lot of time urologists will also put you on something called an anticholinergic, or a medication that relaxes the bladder, because the spasm can hurt. And so the bladder is a simple organ that just senses if there's anything in it. So the stent is a foreign body that technically is in the bladder, and what the stent does is it's constantly going to rub against the bladder. So when you have a stent in place, you can get bleeding coming from where it irritates the kidney or the bladder. But but you're really not going to lose a ton of blood from that. Just think of it like this: you go in the toilet, take some food coloring, put a couple drop in, and you see the whole thing turns red. But if you don't know that and you just see the blood, you're like, oh my God, I'm losing liters of blood. No. So the kidney, and the bladder gets irritated. So that's why when you have stents in, if you have a lot of activity, you may notice some bloody urine, which is completely normal. That's nothing for you to freak out about, unless, your blood pressure is dropping and stuff, which I personally never seen, or you're turning pale or whatnot. Now, what is the rationale for just putting a stent up? Well, some surgeons, like I said, this is all surgeon preference, okay? So some surgeons, if they go in there and it just looks really, that same 47-year-old gentleman, the pain, morphine and all that's not controlling his pain. So then now they take the patient back. And, that surgeon has two options. One is, now this is assuming you don't have an infection. If you have an infection, then the best course of action is put a stent in. Now, if you don't have a urologist available, then the other option is you can have interventional radiology put a tube. They just stick a little stab in your back. And a lot of them can do it under conscious sedation, like, you're getting a colonoscopy, and then they just do it under ultrasound. But what they'll do is they'll just put basically a drainage tube into the kidney that curls up just like the stent. And then you can divert the urine that way too. Because remember, kidney stones don't damage the kidney. It's the backup of the urine that damages the kidney. Now, is there data to suggest which one is better? No. It just depends on who's lazier. If the urologist is lazier, then that patient's going to get a nephrostomy tube. If the interventional radiologist is lazier, then that patient's going to get a ureteral stent. Don't tell them I told you that, but that is unfortunately that's the fact of life. Okay. Or if it occurs, if the gentleman came in at 2 p.m., most likely he'll get a stent. Most likely he'll get a nephrostomy tube. If the guy comes in at 11 p.m., then most likely you'll get a ureteral stent, because interventional radiologists, they, some reason after 5, they don't function. I don't know why. And this is across the nation, not just in Texas. It just happens that in Texas, the interventional radiologists are a little bit lazier, but I don't have data to prove that. That's unpublished data right now. I do have data, it's just unpublished. Okay. So now this is all temporizing measure. Okay. Now, the only argument I would make to place a stent instead of the nephrostomy tube, except when I'm on call. When I'm not on call, when I'm not on call, then what I suggest is you put a stent up, and basically the stent can passively dilate the ureter and allow the stone to pass on its own. Okay. So there is benefit to having the stent in terms of stone passage, but you also run the other risk of an impacted stone, because if the stone has been there for a while, it causes a lot of inflammation. And when you try to put up a stent, you're actually having to put, like a wire to kind of guide you up into the kidney so that then you pass the stent up. Well, if it's been impacted and the tissue is inflamed, you can actually puncture through the ureter. So it's not without risk. And that's why there's really no data to suggest whether nephrostomy tube is superior or inferior to a ureteral stent. Okay. And so now, if the urine is clear, the patient has a ton of pain, can't be controlled, then yes, you can also still temporize with the stent, or you can just definitively take care of the stone. And what do I mean by that? Well, if it's right at the ureteral orifice, or it doesn't matter where it's at, but let's just say that it's right where the ureter and the bladder meet. Well, it's right there. If you have the laser available, then just laser that stone up into dust. And then, and then you took care of the stone for the patient. And then typically a lot of urologists will leave a stent in place. And believe it or not, these stents come with a string, so that, you don't really need to come back to have it removed. You can actually remove it at home. So If it's an uncomplicated ureteroscopy, and ureteroscopy means putting the camera, using the camera so that you can laser that stone. If it's uncomplicated, you can actually just leave the stent so, everything kind of heal, calm down a little bit because of, surgery is really controlled trauma, right? And so you're controlling that trauma, and so you're going to have inflammation. So then you have the patient just remove the the stent in 3 days or whatnot. And then typically you'll take that stone and send it off for stone analysis to help kind of, later on with other tests to kind of help figure out, well, why did the patient have a kidney stone in the first place, and then try to prevent it. Now, I'm just going to mention briefly. So in children, typically after the first episode of stone, I just do a stone workup. And usually the stone workup is fairly simple. It just requires some simple labs and then a 24-hour urine. And so that usually they'll send a jug to your house. You just urinate in there the amount that they want you to urinate, and then you send it back for analysis. Or your urologist can do that, or they can just refer you to a nephrologist who can also do that. In adults, there's really no real criteria on when you should do the stone workup. And I won't go into, some people don't even think you even need a stone workup, because the most common cause is dehydration and with low citrate. And so citrate, you can be found in lime and all sorts of stuff. And so now you can take pills for citrate, but it's like a horse pill. I've never personally taken it, but that's one of the factors that is hard for a patient who needs citrate. But I won't get into the debate of, because there are some camps that think you don't even need a stone workup. You can, just draw some certain labs. But back to this gentleman. So those are his two, those are really his 3 options actually. Yeah, is if no urologist available, nephrostomy tube can divert the urine and that patient can safely be discharged. If a urologist is available and, he comes in, he can either put a stent in and, let it passively dilate so that, let the stone try to pass on its own. Or if there's no infection, the key is infection. If you have infection, then don't mess around with that stone. You can make that patient septic. And so if you don't have an infection, then, then it's really up to the urologist. And what I've noticed is if it's in the middle of the night, most likely you're just going to get a stent. If it's during the day, then they'll probably laser it. And it doesn't have to do with the urologist being lazy or not. It's just a lot of hospitals don't actually own the laser or have the laser in-house. So they contract it out to a bigger company. And so unfortunately, the laser may not be available. And a lot of time in the middle of the night, it is not available. And so your only choice is just to put the stent in to stabilize the patient. Now, if the patient comes in, same patient, but now this time there is an infection, well, then you really should send the urine for a culture and then empirically cover him or her with some broad spectrum antibiotics. And then in that scenario, either do a percutaneous nephrostomy tube with interventional radiology to divert the urine, or place a stent and then treat the patient for a few days. And then you can come back and with antibiotics after you treat them for a few days, then you can come back and take care of the stone. Now, does the patient need to be treated in-house? Not really. So what I mean by that is once you place the stent and, electrolytes are okay, white blood cell count's okay, patient's doing fine, patient's eating fine and all that, yeah, you can discharge the patient and then just take care of the stone as an outpatient. And, whether now some urologists, if they have, like I said, it's really up to the surgeon, but if they feel like, that's a small stone, the ureter was pretty wide, then the stent, probably dilated it. Then they can sometimes what they'll do is they'll reorder a CT stone protocol, and CT stone protocol just means that there's no contrast because all you just want to see if there's the stone, and so that if the patient doesn't strain the urine or whatnot, then they'll order the image, make sure to see if the stone is still really there, and if it is, then you can take them back for the operating room. Versus if the patient strained the urine and the urine is gone, then and you saw the previous CAT scan, it only had that one stone. The patient brings you this one brown little stone that matches the 5 millimeter. Well, then you can actually remove the stent in the office. And then like I said, and then from there, you can do a stone workup, or you can wait until another episode and do a stone workup. Or if the patient has a history of stones, then regardless of whether intervention was needed or not, meaning that all the other time is spontaneously passed, then I probably just get a stone workup just to see it could be something simple to treat. And so that's pretty much kind of the broad kind of a broad picture of stones. Okay, now you can have stones that are very large, and basically there's no way it's going to pass. So 2 centimeter, 3 centimeter. Well, if it's that big, a lot of times urologists will do a procedure called a percutaneous nephrocutaneous lithotripsy, and PCNLs for short. And what that is they actually have interventional radiologists, or if the urologist is comfortable getting his own access, they will make a access through the back of the kidney. And then, you can dilate it up to like a way bigger French, like, 26, 28. So, because if you have a 3 centimeter stone and you try to laser it with these tiny laser, and the laser comes in like 200 nanometer, 360 nanometer, I mean, you're going to be there all day. Trying to break up a 3 centimeter stone. So what they'll do is they'll just go in through the back, because now you have better equipment, because you have a bigger working space. Like, you're not going to be able to work in the ureter with that big of a equipment. So just as an example, basically the ureter, typically you're working with a 6 French ureteroscope, okay? And now you're talking about trying to use instruments that requires like a 30 French to enter. Well, that's physically it's not going to be possible. And these laser fiber are very tiny. And so I know 3 centimeter may not sound like a lot, but that's huge. Now, another way of taking care of the stone is something called ESWL. And what that is shockwave lithotripsy. And what that does is basically it just uses shockwave from the outside to break up the stone into sand, and basically, or into tiny fragments. And, there's X amount of shocks you can give on each side. And so that's also an option. I personally don't like that, just because basically if you do uroscopy where you go in with the laser and all that, or PCNL where you go in through the back for bigger stones, then you got the stone, everything's done with, you don't need to worry about like fragments and stuff like that. That's assuming if you do a good job on the initial uroscopy. And so, but that's pretty much kind of the management of kidney stones. It's not very complicated at all. And so, so next time, if you suddenly have like severe pain in your back or whatnot, one of the things just to keep in mind is that, especially if you have a history of it or you have a family history of it, is, kidney stones. And so, so those are questions that, let's say you show up to the ER, those are questions you ask, you can ask your urologist. Hey, I saw this YouTube video, or I download this podcast, and Dr. Pham was talking about my urine's clear. He was talking about can you just take care of the stone, or do you have to put a stent in? So basically, with this episode, what I want the audience to get from it is, with this episode just now, that should be enough for you to understand what's going on and have that conversation with your urologist when he comes see you. So, and then if they go, oh, we don't have any urology on call, then ask them, well, do you guys have interventional radiology on call? Because you really don't need to be transferred if there's a interventional radiologist on call, because they can divert the urine the other way too. Okay. And so now, because I don't want to take up too much time, but we'll talk about next time. We'll have a part 2 where I'll talk about basically what criteria is it that you don't do observation or letting it pass passively. Okay, so because, or what we call what we call medical expulsion therapy. And so, but we'll talk about that in part 2. So because the stone, there's a lot of stuff to cover. Okay. Well, if you find it helpful, please subscribe, please comment. Because the more people who watch and download this, then then I'll keep going at it. And my whole purpose is just to kind of shed the light on urologic issues. So that you have the right questions to ask and all that. But remember, do not self-diagnose and do not self-treat. Basically, these are just things to have in your mind when you do undergo treatment. Then you know the right questions to ask. Okay. All right, this is Dr. Pham signing off. Until next time.
We gon' do it like it's priceless. Take it to the moon. Priceless. One day will be soon. Like it's priceless.